Okay, good morning. I'm Doug Meade with the U.S. team, and I'm going to present you some results. We've been working with our healthcare agency, Center for Medicare Medicaid Services. And I was explaining yesterday, in many ways, this is the largest government agency because there's a huge amount of healthcare spending in USA, and this is the agency that manages all the flow of this spending to the consumers. And this project came up because the question was asked, the US is spending more and more percent of GDP on healthcare. But if we look at the income side, the earnings of doctors and nurses and other healthcare workers, we don't see nearly this large share. So where is it? And we told them, oh, this is easy to understand if you use input-output techniques, which they've already been hiring us to use our lift model to do long-term forecasting as well as 10-year forecast. And we said the answer can be very easily explained. But the presentation of it we found was very difficult because even though this is my presentation is quite simple. I think many of you who know input-output, you say, what's the point? What's the big deal? But this was actually very revealing to people in this agency, and they got very excited about it. So it just goes to show that what we as input-output economists think is obvious, maybe to many people is not so obvious. So I think this very simple idea of the indirect requirements and where does the output come from is very illustrative. And the other thing I wanted to say before getting started is that I did this study for healthcare because of its large importance in the USA economy. But this could be done for any kind of final use, whether it be energy or agriculture or transportation. Every industry is basically in the IO system working the same. It has a direct provision to final demand, but there's also the indirect suppliers behind of that in the end, it must add up. So I'm going to go through some of this background about healthcare first and then explain what we did. So the outline of the talk is, I'm going to talk first about these National Health Accounts. We have two sets of accounts used in this study. One is the National Income and Product Accounts, which we call NHEA for short. This is like the S&A for the US. The US has a different system than every other country. It's called NHEA, and this is our GDP accounts, and also our input-output accounts are made by the same agency. The other accounts are these national health accounts. And if you've ever worked with two different sets of accounts, I know, for example, you have worked with energy and trying to reconcile energy accounts to input-output accounts, you find the numbers are different. It's sometimes very difficult to reconcile. So that was part of our problem, was looking at these national health accounts and figuring how they corresponded. I'm going to show you a few figures about healthcare spending. If you haven't looked at these before for the United States, they're fairly astounding. Then talk a bit about the motivation of the study and show you the calculation and results. The study is still ongoing. We're revisiting this question that we had worked with before, but now we have some ideas to take this a little deeper, and I'll just mention those at the very end. So first, just a few facts. We have 17.9, almost 18% of our GDP is spent on healthcare. On the demand side, we have lots of data, lots of information in very high detail, what kinds of treatments, what kinds of hospitals and doctors. But on the supply side, we just see this a small percent, 6.3% of GDP. And so where's the difference? So we'll explore pharmaceuticals, which is one of the sources of indirect demand, the machinery to provide the investments, also retail and services industries, and then trade and transportation. So if we look across different countries in the world, we see they fall on this spectrum. This is the share of healthcare to GDP in nominal terms. And you see the USA over here on the left. And the shares are somewhat correlated with the income level. So higher income countries tend to have higher share of spending on health. But it's not a straight relationship. In other words, some countries that have a very high income can have a fairly low expenditure on health, and some other countries with a lower income have higher. And you might also think that because USA has such high spending, we're very healthy people. We live a long time, and our babies are very successful at not dying, and we don't have many incurable diseases. Not true. We're not one of the most healthy countries. We're way down the list. In the OECD ranking, we're something like the 24th in terms of their measures of health indicators. So for all this money we spend, we're not so healthy. But we have maybe cultural or societal problems like obesity, alcoholism, and these days we also have a huge opioid drug addiction epidemic in the United States, which is killing many people. So we have problems that are not coming from lack of spending on health, but they're from other sides. But if you see the middle tier of countries here, France, Germany, Japan, Canada, these are the upper income countries that are also fairly large. And you see they're clustering all around this 10% level. So you might say USA should be something like that. If we look over time, the red line shows the growth rate of these healthcare expenditures, and they're not steady, big changes from year to year. The blue line is showing our GDP, and these are still nominal figures. We haven't adjusted for inflation. And you can see pretty consistently the healthcare has grown faster than GDP, even back in the 1960s era. So the result of this is the share of the GDP was only about 4.5% back in 1960 when I was a small child, and growing to this high level now. We've had some periods, like right in here, where people say, oh, the healthcare expenditure problem has been solved. We have a flattening of growth. But then again, it marched up. So we've had, in recent years, a fairly low growth, which people, again, are congratulating themselves and saying, oh, we've solved the problem. It's not going to go so high. But we do this long-term forecasting for this agency where we go out to 2095. It's kind of hard to imagine what this year, 2095, looks like. But we have to go out 75-year forecast for them. And part of the question is, what will be the share of US GDP spending on healthcare? And only several years ago we were doing this. The answer, they would tell us what it had to be. They said it was 50%. I said, really, 50%? Yes, 50% of your GDP is healthcare. Part of our analysis was to show them how unsustainable this kind of share was. What did this mean for the rest of the economy? And we could trace through our model and show what did this mean for all the other sectors. So recently they've come down their forecast, but still we expect easily going up to 25%. So this is a very strange phenomena that we have in the USA. I'm sorry. So this is a picture of these National Health Accounts. They actually have incredible detail below these numbers, but these are the top line items. And so in this table, we have US GDP on the top, currently about 19.5 trillion in 2017. National health expenditures is here, about $3.5 trillion. The health spending is greater than the GDP of many countries. And these are the percents of GDP. And then we break this down. The biggest component is called personal health care. And then of that, the biggest pieces are hospital and physician and clinical. So these are what most people see when they think of health care. They go to the doctor says, you're in trouble, you need an operation, you got to go to the hospital. And that's where you spend the big money. But there's many other services that are also important. Dental, other professional, like even drug addiction care or mental health. When we get old, America is becoming a very old society now, like many European countries. We have a lot of nursing home care expenditures. And then, of course, the one that's the most in the news is prescription drugs. And so when we look at the percent growth, this average over this whole period, 6.5 nominal GDP, nearly 9% for health. And then you can look inside of the healthcare and you see it's quite different across different components. So the two biggest pieces, the hospital and physicians, are about like the average, about 8.9. But some of the other components, especially once you look at the insurance, is a little bit higher. So one other feature of our system is that this insurance cost is going up and up and up. It's costing more to provide insurance in the United States. And so this is another picture of this kind of mystery, you might say, as we were told, that many reporters came out and said, oh, it's not really, what you're saying is not correct, because here's the value added. It's maintained a small share of GDP. This is now starting in 1998. And this can't be true up here because it's growing and it's so much larger. So, you know, how do we reconcile these two pieces of information? So the way to think about it, we actually gave kind of a couple of presentations that just explained input-output, the basics of input-output in national accounting. How does it work? And so from the national accounting, we can look at the C plus I plus G, you're familiar with the expenditure side. And this is the measure that shows us healthcare is about 18% of the economy. On the supply side, we have the GDP as a sum of value added by industry. And for an example, here we can make a statement, manufacturing is only 10% of the US economy, looking at value added, or healthcare is 6.3%. And in the end, these two measures of GDP must be equal. So for every dollar of final expenditure, it needs to go somewhere in the income side, and in the end, we add all those industries together, we'll get the same final number. And this is just a graphical picture, which I know you're familiar with, but in the end, this box down here has got to be equal to this box, which is GDP. And so now we'll look at a couple of the calculations. These are the main steps, but they're really fairly simple. The first one takes a lot of time, which is going through all of these detailed health expenditures and finding out where are these in the national accounts. How do we reconcile the spending in NHE, National Health Accounts, with our national accounts? And then we build a bridge. If you build IO models, you're familiar with these bridge matrices, like a consumption bridge or investment bridge, that bridge some final demand spending down to commodity. Well, for this, we built a healthcare bridge. So for these different components of health, we can see what commodities make them up. And then we calculate the healthcare demand by this final demand commodity. We have 121 in our lift model, and then use a standard Leontief identity to get the total requirements. Again, we're just looking at the domestic side, so I'll talk in a bit about the imports. Where does this show up? And then we calculate the indirect requirements and indirect imports. To go to looking at value added in employment, we need to think about industries instead of commodities. So we make a transformation to get to the industry output, and then get our value added and employment. And these pictures of employment are particularly interesting because it shows you, how many people are actually employed supplying to healthcare, and they're employed in many different ways. So here's, I'm sorry this is such small type, but this is just an example of the reconciliation. So one that's pretty easy is hospitals. They're not all that close, however. This one is the National Health Accounts, 1.1 trillion, and I believe this is 2017. And in NHEA, we have in the personal consumption expenditures accounts just a little over 1 trillion. So there is a difference here. This one we did not try to reconcile, and for the following reason. What we're trying to show is the sort of the direct and indirect implication of the national health spending itself. So we're taking this number as our driver. We're trying to get it as close as possible to the national income numbers, but allowing for a few differences. When we go to something like physicians, we started off with a much bigger number in the health accounts than just the physicians' number in our national accounts. But if you read the footnotes and the methodology of the health accounts, you realize they're including other things in this physician and clinical number. And a big one is this outpatient care facilities. These are after you leave the hospital and so you have heart surgery, you're not really able to go back to work again. You're still very weak. You go to outpatient care to get some maybe physical therapy or other treatments of drugs or something. And then this is just some of the other categories, how we got to line them up. Nursing home was another interesting one because the nursing homes themselves provide a lot of other services there at the nursing home center. And so with information that we had from our IO model, from our personal consumption bridge, and also information from these health accounts, we built this bridge matrix. So for the National Health Accounts, we have 16 categories of spending, and we bridge these through this bridge. The coefficients sum to 1. So this is essentially just a remapping, sharing out expenditures from these 16 categories to get to the number here, the final demand. And we strip off the import component, and we have the domestic final demand. And this shows you the results, just kind of the major shares. Now this looks a little bit like the table I was showing before, but that was the table by National Health Accounts categories. This is now the input-output commodities. So the biggest one is still the hospital, 34%, physicians or doctors, 15%, nursing care, insurance, pharmaceuticals, 5%. But we also have new industries showing up like other retail and wholesale trades. These are some of the margins of providing goods, mainly drugs, to consumers and hospitals that are now showing up even in the direct demand, because these are part of the direct cost of providing drugs. After we do the input-output calculation, we can look at how much of this commodity is from the direct spending on health, and how much is indirect. How much is the industry back of that? And so the blue is the direct, and for something like hospitals, it's pretty much all direct spending, as it is for doctors. But for the insurance, for example, it's about half and half. So this, once you look at the total requirements, it's quite a big number. And this is partly because the insurance industry itself, we were talking during Henrik's talk about diagonal. In the IO table, the spending of the industry for its own product is what's called the diagonal. It's often quite large. In the insurance industry, this involves insurance companies have to buy insurance themselves. They call this reinsurance. And so for healthcare in particular, it's a very big amount. They have to purchase reinsurance. They're purchasing also different types of insurance from other companies to provide the health insurance. Furthermore, the hospitals and the doctors have to buy their own insurance. It's a big deal in the US. It's called malpractice insurance. So if anything goes wrong, the doctor, oops, just cuts your jugular vein, you die, I'm sorry. Your wife might choose to sue him, or a greedy lawyer might persuade her to do so. And they have insurance against these kind of things, so we have a lot of indirect purchases of insurance. Some of the other components, like other real estate, it's all indirect. So this is the rental of the buildings. The hospital's not owned, it's being rented by somebody else. Any kind of real estate activity. And then finally, the other, over at the far end, it's one of the biggest. It's a whole group of many different industries, maybe 60 or 70 industries, and you see most of their output is the indirect side. So this is kind of the mystery industry here. Not easy to display in a PowerPoint because there's so many things. They'd be too small to look at. After we calculate the total requirements and we convert them to industry, we can also figure out where's the value added. So this is kind of the end point of our work. What are we trying to get at? How is this value added looking compared to the final expenditure? And the magic number is what is the share of this value added in GDP? And also what's interesting is the growth rate. So over this particular period, this is a smaller period than I showed earlier. Everything's a little bit slower here. 1998 to 2017, we had 4.1% GDP growth, nearly 6% national health spending. The value-added component that we've calculated is 5.5%, so a little bit slower and a little bit smaller. And we'll see why in a minute. And then in terms of the overall value added, still a lot of it is down here in the healthcare sectors. This ambulatory health services is basically everything except for hospital and nursing home. And then here's the hospital value added. So there's two things you can notice about the hospitals per se. You might remember that earlier I said hospitals is about $1.1 trillion in direct spending. So the value added is just slightly more than half of that. So much more of this hospital spending is not going to income. It's going to purchase from other industries. It might be equipment, test equipment. It might be medical care products, all kinds of things they have to buy. These tubes they put up your nose or something like that. Different types of hospital products. So the actual earnings, and this includes not just the doctors and all the hospital workers, but also any capital income, any investment income, is $600 million. So already there we've shown that a lot of this value added has to go elsewhere. And some of the other big industries are in manufacturing. We have durable and non-durable. In particular, in manufacturing, there's a lot of manufacturing of pharmaceuticals. We also have a big sector of trade, wholesale and retail trade, in providing all these goods. And then for the employment, this is particularly interesting. So you remember the healthcare spending itself was about 17.9% GDP. Once we looked at domestic value added in this previous slide, 16.3%, a bit less. We're going to look at why. And now for employment, we have 19.6%. So this is just domestic economy. We have a bigger share of workers supporting healthcare than we have as a percent of GDP. So what this means is that the average productivity level, in other words, the average value added per employee in the sector supporting healthcare, it's actually less than average. We think of the reason that we pay so much for healthcare is because these doctors, they drive around the BMW and they're nice clothes and everything, big house. They're so rich, they're overpaid. Well, there may be a few like this, heart surgeons and very well-paid doctors, but for the most part, people in the healthcare industry are not paid really highly. Furthermore, as we saw, many of the industries that support healthcare are wholesale and retail trade. These sectors are also not paid really highly. So the reason that we have an even higher share of employment here is that it takes more workers per value-added dollar to provide this value added. And then the final graph is kind of a reconciliation of what we've seen before. So there's a lot going on here. I'm just going to point out a few things. Basically, the question we're trying to get to is where is all the value added? So the number that we have here is our National Health Expenditure in 2017. This is the value added, this is the value added here from domestic production. It's about a little more than 200 billion less. So we're losing some of it from direct demand imports. So as we purchase, for example, pharmaceuticals, a lot of pharmaceuticals are imported from other countries. Some of that is leaked through imports. And then also from the indirect demand, as we purchase all these other types of manufacturing and equipment, they're also generating imports. So the total value added, we say leaked because of imports, 227 billion. So ideally, these two numbers should add up exactly to this. But we understand we have some imperfections or measurement error in our data. And so we have this one final column here called unattributed. It's pretty small. But basically, we're able to allocate all of this spending to either some industry or to imports. And so the graph that kind of shows all of this is this blue and red were kind of similar to what we were seeing before. The red is what we actually measure in healthcare value added. But as we break it down, we have some which is the direct imports, and then the indirect imports, and then this unallocated, or maybe you might say error term up here at the top. We're still fighting with this one, trying to make it go to zero. So we're learning a lot more about our data set and its imperfections by working on this. But what we're more interested in is what I'm talking about in this last slide. So there's a couple of interesting problems that I think also as input-output economists you should be interested in. And the one is, as you look at this set of total requirements or indirect requirements, you see if we look at it by major shares of the economy, for healthcare sector in particular, versus services, versus manufacturing and trade, we see some pretty large shifts in the distribution of these industries. So what's causing this? We look over a 40-year period, you can see, as with many other things, manufacturing going down, services going up. So I think there's really three main factors to look at. One is the labor productivity by industry, and also for value added, these value added output ratios changing. The other one is we've been importing more and more as a share of GDP. So these changes in import share are important. And then something that Henrik was talking about in his talk, the A matrix itself, or you might say the reality of inverse itself, is shifting over time. So this changing structure of the A matrix is also part of what's generating, for example, this lower manufacturing share. So productivity, imports, structural change, and we're going to do a decomposition analysis to try to understand how much of each of these impacts is responsible for the changes. The other thing we want to do, all the analysis I did so far is in nominal terms. We have not deflated anything. And I think the deflation is really where the difficulties lie, but it's also where you get the most interesting results, because you want to see what's happening after inflation. How much of this healthcare is growing in real terms and how much the components are growing. And from the dual perspective, we can look at, can we say what is the cause of the growing healthcare prices? So not only is healthcare growing faster in nominal terms, but the price of healthcare is growing faster than the price of average GDP. So what's driving this price change? Can we look at the, is it only concentrated in the healthcare industries itself, or is it also in the supplying industries? And then we're going to be working with some projections as well. So this has all been historical work. We're going to take it forward to a 10-year projection, which is a project we do with this agency, and also look at the occupational employment. They've talked about doing these long-run projections with this. It's possible. We've built in this kind of framework into our main model, so we can run the model out pretty far. May look at the long-term impacts. So this is what I had for you today, and I hope to be able to continue this project, maybe in some future conference, tell you some more interesting results.
Very interesting. Questions?
Doug, thank you for a very interesting report. Can you explain more carefully impact in healthcare, especially direct and indirect impact? What you have in mind, and what kind of statistics, American statistics, you have in this field?
Okay. Yeah, so lying behind all this work is a big project we've been working on, which is a compilation of a time series of detailed input-output tables. Right now we're building them from 1997 to 2017. So these are helped a lot by what the BEA provides to us. And inside of these IO tables, we have, of course, the imports for each commodity. We can get the import share. And we have in the historical database some estimates of imports by commodity. So as we get demand for any particular good, usually, there are some services, trade as well, but indirect imports, as we generate, we go through an iterative loop to calculate the total requirements. And each cycle of that loop, some of that demand goes to imports. So let's say they're requiring, way down the line, steel. Steel is needed to make some machinery, which is used in the X-ray equipment in the hospital or something. Well, this steel, most likely these days, not made in USA, made in Korea or China or something like that.
Some agreement.
Yeah, certainly too, yeah.
Now, mine is a short one. How did you deal with insurance in medical schemes? I'm just worried that you double count there, but might be you can explain to us.
Yeah. Definitely, when we're looking at output, we're double counting, because there we got the insurance, buying insurance, so we're counting both of those. But when we go to value added or employment, the double counting goes away, because there we're looking at the employment or value added at each level. So direct, indirect behind that. So there's no double counting for value added or employment. But yeah, for the total requirements, there's a lot.
One last. Two.
I have two questions. One is more theoretical, but important from point of view of practical material.
the product of healthcare sector. How do you think? Is it more private or more public? And is it possible to divide these parts?
Yeah. The question was relating to public versus private. And this is a really interesting question because if you study basic economics, like I've been working with my undergraduate research assistants, and they're now studying undergraduate microeconomics, and kind of talking with them about what they're studying. And the one question was, should a good or service be provided by the government, or should it be provided privately? And then if you look across all of the countries, there's incredible differences. Well, the answer is, in the USA, it's mostly private sector, doctors and hospitals. But of course, my wife comes from Germany. It's pretty much all public sector. So, and also nobody lacks health care in Germany. Whereas in America, we have about 30 or 40 million people with no health care insurance. So the American system is very much oriented towards private sector. That said, we have a huge set of people who are either currently or formerly in the military. And they have a very generous healthcare arrangement. So they have their own both healthcare system as well as retired healthcare. And that's all government provided. And there's a few other examples of government healthcare. Some of the hospitals, for example, in many states are either local, state-run, or some other municipality owned by government. But they're going away, I'd say. We used to have many more nonprofit and government hospitals, but these days these large corporations, large hospital corporations, are taking over many of the hospitals. So the government hospital may find it's not making enough money to stay in business, and it shuts its doors. But then one of these big companies, they buy the hospital and they open it back up again, but now it's a corporation, not a government anymore.
And if you use assumption that all sector which is from public sector have the features of public goods, it's okay. And put it into production, into the consumer functions, because it's direct. It's okay, it will be okay, this assumption.
I'm sorry, what is the question?
If it's founded by public sector, can we assume, you look at statistics, that it is mostly public good, or not? Or it's
yes, it's still a bit private because in the case of the military, of course, it's a public good, but it's a public good for a certain set of members. You have to be military or ex-military, so it's not for everybody. The other ones, they provide services for a fee, just like the private hospital. They're run by government, but they're not giving away anything, maybe except for emergency room care. But most of the other services you have to pay, and the hospital's not getting any subsidy, or not very much subsidy from the government. So it's almost like a private hospital. Yeah.
Thank you very much. And the second one, a little bit less, idea of different types of accounting in public and private sector. Maybe it influences to this difference between value-added and final demand volumes.
Yes, that's
Can it be possible or not?
I used to work at the Bureau of Economic Analysis where we build the input-output tables, and these government-run hospitals were a big problem because it was harder to find information on their input cost than from the private sector hospitals. So sometimes we had to impute and make believe that it was similar to private sector. We didn't have any data. So
especially profit, pure profit.
Yeah,
Maybe
that's right.
less than real.
Good question.
Okay, this is gonna be the last one.
Thank you very much. Doug, thank you for a very interesting presentation. I was surprised when I saw continuous growth of share healthcare industry in GDP since 1960s. And my question is about how can I estimate share of export in healthcare services in the United States? I have one example. In Russia, it is a popular service for rich people, childbirth in Miami, for example.
Yeah,
Thank you.
this is a growing business, exporting healthcare. And we have one of the largest centers of healthcare export in Texas, USA. It's a huge facility, many acres of land, all types of healthcare, and they even have their own airport there. So rich people from, say, Russia can fly in and have a very special surgery performed at this center, and it's counted in our accounts as export of healthcare. But at least today, it's still a very tiny share. So it doesn't even really show up on the graph, but it's forecast to be growing.
I have one question from the field of modeling. Of course, it's very useful, interesting investigation, but if we speak about modeling in input-output models, I have very hard discussion with my colleague Vadim Potapenko about connection health expenditures and human capital and different kind of demography. And what is your position? Can we connect health expenditures and demographic projections in the future or not?
Oh yeah, I didn't really talk about this, but in our lift model, we have consumption equations. So for about 92 different goods and services, several of them are healthcare. I think about 5 are healthcare, and these are looking at the share of different age groups. We have the age group by 5-year roughly, and of course the elderly people are using more healthcare, both nursing home and hospital. But maybe your question also relates to, does the better healthcare results affect the demographic forecast? This we haven't done as much work in, but for some particular studies, we've looked at this kind of question where they want to see what's the growth rate of population going to be if we can, or of labor force, if we can extend the useful life of workers. So,
Thank you very much, Doug. You're in a So